There you go. Going there again?
Yeah, it's being recorded now.
Okay then.
All right, thank you.
Welcome. I can't see the chats when we're in class, okay?
Okay, so we'll use the mic.
So yes, so use your mic because I can't in this section I can't see the chats. It's a little bit harder for me to see. Let's continue on from here. So we'll go back to milestones. Remember that these are specific skills used to mark the progress of a child's development, and they represent a mean age of accomplishment of skills, which then means that we get a group of people together from a similar population, we find out when they've achieved a skill, but there has to be room for those who do it early, some for those who do it late, but it can't be that the entire population will be fitted in as late. So you will end up taking what most of the population will be able to do at a certain time, and that will be considered as your typical or normal group. So 96% of the population will be covered. Within that 96% of population where you consider would be doing it in what is expected a normal time, know that there are different degrees. People will be doing it early, some will be a little later. It's just that they haven't crossed the bar yet to say that their lateness is significant. So the milestones will then that we've obtained from these will be used for monitoring during evaluation of the health and well-being of our children. So the senior clerkships, I figured you've all gone through every single notes that you did from third year. Am I right? Yes, I'm right. Yes, I'm right. Yes, I'm right.
Well, Doc, eventually,
Yes,
but not right now.
no, man, you don't hear me. We are right. You can't tell me I'm wrong at the beginning of my lecture and at the beginning of the school year. So I'm right. So I'm going to ask you for 5 volunteers, and don't worry, you don't need dates. All we're going to go through is the process that occurs in terms of development. We don't need to know the exact times. We just need to know more or less the order, and nobody's penalized for anything, and it's not graded. But it prompts us to remember what we need to go. So I'm asking for the first volunteer. You don't pick yourself, then I will find that list and start going through names. May I have my first volunteer?
Morning, Doc.
Morning. Who's that speaking up?
Christian Edwards.
Christian, okay. Can you find a friend who will join you? One friend. Just choose from the list whoever you like or may dislike at this point in time.
Daniel Drakes.
Daniel what?
Drakes.
Drakes. Okay, Christian and Daniel, we're going to start going through our gross motor milestones. And it's not meant to be a test or to show any shortcomings or anything like that. All it's meant to be is for us to go through the process of what you would expect when you talk about gross motor development in a child. So we start at the very beginning. We don't have to give ages. We just need to be able to go through what is expected. So Daniel and Christian, you can start off for me. If they go wrong along the way.
So the first one, I believe, is raising, the baby will raise its head from the prone position.
Is there anything that's maybe just before that or just around the same time as well? Others can answer.
Is it that
rolling over that?
No, sir. Come back again. Come back again.
Is it that they have?
As I said, we're just reviewing. I can't see the participants chat, so I asked that somebody monitors it and just checks in there.
Oh, Doc, I was asking if is it that they can turn the head side to side?
Turn your head from side to side. So you often look at the newborns when you go up to ONG, right? Because you've been up there and you've just bathed the baby and you put the baby down, or even on ward 11. What's the most you realize the baby is trying to do? Is literally just barely moving that head from side to side. Next, then they start pulling up that head And then it's a gradual process for a head to really get up. What else do we see after that?
Do they try to roll to the side?
Mm-hmm. Not but before rolling though, because we're just barely putting up our heads. What's the peak of putting up the head that you usually see documented in your milestone chart?
Doc, is it that they can support their heads? Like,
Chest up, arm support, right? So they're down on their tummies, the shoulders and the elbows are on the bed, and they're able to lift their chest, not just the head, but the chest comes clear off the bed. And what happens after that now?
Roll over.
You topple right over and you roll over. So first we move on our heads. We move our heads from side to side. We get our heads up a little bit. Then we clear the chest off the bed, chest up, arm support. Next we roll over. After we roll over, what do we do? Danielle and Christian, I don't hear you.
Yes, Doc. After they raise their head, they hold it in the midline position, and that's when they have their chest off the table and they support themselves with their
Yes,
forearm.
and after that we roll over. After rolling over, what do we do?
They could sit unsupported, so they could hold themselves upright.
And what's when we sit with our two legs stretched out and one arm to ankles? What's that called?
I'm not
I give you
sure.
the hint. Two legs out, one arm to ankle. How many appendages are down then?
Tripoding?
3.
Tripod, yes. So remember, the other hand has the toy that they want. So it's a tripod, and then you learn to sit up completely, straight up, back, no back support, but the back is nice and straight. And after that, what do you do?
They could turn while sitting, so they could pivot and like move around, like rotate their body while they're sitting up and playing.
So they can sit up, hold objects in both hands, and you can see them swing from side to side, trying to reach for other things. What happens after that?
Around that time, I think they start pulling at like surfaces to try stand up.
What do they do maybe before pulling to stand? And this is Daniel,
Crawling.
right?
Yes, Doc.
Where's Christian?
So before
Um,
standing, you'd be trying to crawl, Doc.
Okay, so after you learn to sit up and you pivot, you usually end up flopping forward and you get into what's referred to as a 4-point crawl. Can you describe that for me, Christian?
Not really, no, Doc.
No, but it's 4-point and we
Mm-hmm.
have 4 limbs, right?
Right.
So we expect both knees on the ground, not the entire leg on the ground, but the knees on the ground,
Mm-hmm.
flexed, and then the 2 arms down, and they're crawling on all fours, and that's a 4-point crawl. Do you remember any other type of crawling positions that may occur? When little boys are playing soldiers, how do they crawl on the ground in the grass?
Knees down and forearm down on the ground.
Describe for me. I can't
Um,
picture knees down and forearms down.
so the knee would be on the ground, and instead of the hand on the ground, you would have the entire upper limb on the ground.
So the knees are usually extended. The entire lower limb is flat on the ground. The chest is on the ground, and you're using your shoulder muscles to move you along. Right? And that's called a commando crawl.
Mm.
So we go from crawling, and then we go where? After we crawl, what do we do next?
After crawling, they start walking but assisted. So they pull up to stand and kind of move, but they have to be holding on to something and they'll be shuffling almost in
What
and
is
stuff.
that called?
Cruising.
Cruising. And then what, from cruising you start to walk independently, right? About how old are we just about that time now?
The cruising to walking is about 9 months to a year in that age bracket.
Okay, so by the time we walk, we're about 12, 13 months, right?
Yes, doc.
Okay. See what I said? I wasn't going to pressure you about ages. That's one of the big ones. After walking, what do we do? Big groups, no?
Walking, they start doing stairs, crawling up the stairs, running. Those.
Mm-hmm. So after we walk, you start running. What else? After you run, you
Skip.
so Daniel, do you have any other friend you'd like to invite?
Um, I don't know.
Look up in the participant list and just choose somebody. Zaria is there. Zaria,
Okay.
after you run, what do you do?
Morning, Doc. So after you run,
Mm-hmm.
you'll start walking up and down stairs.
Before you run, you actually start going up and down stairs. It's just how you go up and down the stairs.
Okay. And alternating the feet instead of just doing like one step.
Non-alternating. Remember, you're still tiny. You're just barely clearing the first rung of the steps. So you go one step up, meet, next step up, meet, before you go alternating.
Mm-hmm.
Okay. And then after you run, what's a big thing at 2 years that you usually do? Parents reach the bottom step and they say, 1, 2, 3,
Oh, they jump.
jump. Okay. So I don't expect you to learn each and every detail, but the big ones you need to cover at least, okay? After you jump, what do you do?
Skip.
Not really.
Hop on one foot.
What happened to the tricycle? When you ride your tricycle, remember we had a little way to remember. Tricycle at 3.
3,
Yes. What happens at 4? So 3 wheels at 3, 4 wheels at 4. And what were the 4 wheels?
Training wheels.
Yeah. You outgrow the tricycle quickly, right? So you go from a tricycle to a bicycle with training wheels. And then somewhere over there after 4 or 5, jumping over obstacles and skipping becomes another one. Hop is before. And then at 6, you're supposed to be back down to how many wheels?
2 wheels.
2 wheels, okay? So that's your typical gross motor development. And if nothing else, it says the gross motor is supposed to be the easiest one to remember. And all it says to us for this morning is that we really need to go over those, otherwise we won't be able to do the stuff that we need to do with the knowledge of the milestones, okay? Okay, and we're going to remember as well that there are some things that after a particular age, we're not, though we do have established milestones, they can vary a bit. And especially when it comes to exposure. So if a kid doesn't have a tricycle, then you need to find an option. So usually we talk about how they go up and down the stairs. And also not even only exposure but practice, even if they have a bicycle or a tricycle, will determine how well they do. So after about age 3, a lot of the skills are a bit repetitive, and it really is associated with being able to practice that skill over and over. So, new volunteers. Zaria, would you like to find some friends now for us to review our fine motor skills?
Sure, Doc. You.
By now, you must go and look up the book and pull out the notes so it makes it easier. I would expect that.
Doc, I actually have my textbook open. Being very honest. Being very
No, but
honest.
so guess what? Now you know the page it is on. See, we've made progress from holiday to school starting. Sarah, you can't find anybody else?
Racine.
Hi, good morning.
Morning. Who's this? I didn't hear the name.
Racine Ramnat.
Okay. So let's start off with you and Zaria can start and get ready to invite another friend for us to swiftly go through our fine motor skills.
Okay, dokes.
Okay.
So, yeah, go ahead, Zara.
They track past the midline.
So the first thing we do is
Track past the midline.
no, we can't track. We have to do something before we can track.
I think they have to fixate on a point.
Fix.
Yeah.
Yes, and that goes very nicely with our social skills, right?
Mm-hmm.
The baby has turned the head from side to side, and if you put them on their back, they can also now look at you and fixate. After they fix, what do?
They have a tight grasp.
No, after they fix, they then track, right?
Mm-hmm.
Okay. Tell me about grasp now.
So I think the grasp that they have is one without like apposition of the thumb. So it's like just flexion of like their, how to say, their
It's a
ends of
closed fist.
things, I guess.
It's a closed fist.
Closed fist, okay.
And that fist closes automatically, right? Once you put pressure at the base of the head of the metacarpals, the hand closes. That's referred to as your
raking.
Open your palm, you put pressure at the base of your metacarpals, and you close your hand. You remember that picture and you realize it's not a raking grasp. It's called your primitive grasp reflex, right?
Yes.
Yes, sir.
And those kids will have that until that grasp starts to disappear because the next skill starts to emerge. So what's the next skill that comes after having that tight fist? What happens after the tight fist? The hand must open, right? Why must the hand open?
Is that like when they do the transferring?
No, you do. It's something you do before you transfer. What do you do before transfer?
They try to reach for things.
The reach for objects. So remember, you have to have that palm open for you to reach for objects, because if you reach for the object with the fist closed, can you ever catch it?
No.
No. So you must, the palm goes from always being closed to gradually, intermittently being open to being fully open. So by 4 months, you start reaching for stuff. Just before you start reaching for stuff, some kids will start looking at their hands. What's that called? When we start, all of a sudden we say, uh-oh, what's that in front of us? What do we have here?
Like awareness of self.
It's awareness of hand play. That's really called hand play.
Oh,
You guys, if you break it down and make it fun, you remember it. So all of a sudden they go from having a closed fist, they start opening it up, and it's like a whole new world. Where did this appendage come from? And then the eyes have fixed, followed, look around, they've seen things, and guess what now? They're reaching out for the objects. After they finish reaching for the object, how are they going to explore that object?
They're gonna have a raking grasp and try to transfer the object.
No. They bat at things, they catch it in their hands, and where do they put it to explore it?
In their mouth?
In their mouth. So they must come to the midline.
Mm-hmm.
And from the midline, what do you do? You put it from one hand to the next hand and you observe it, and it goes back into the mouth for you to be able to explore it. Because the little muscles in the hand haven't really started to do any much work as yet. After 6 months, the hand muscles, the intrinsic muscles of the hand now start to function. It's not that they start to, but they now start to work. And you start to isolate movement. So what will gradually happen? You start to realize that you can not only look at things that are big, but you can look at things of different sizes. And really, you're trying to get down to that tiny size of that bead that you can hold to give you a palm of grass. So eventually, you pick up some objects. You learn to hold it in your hand, not to transfer it now, but to voluntarily place it down on a surface and not just drop it. From there, you start going towards smaller objects, and you start with your grasp. First, you start off on the ulnar side, and eventually, from the ulnar side, you come down to 3 fingers with the thumb, the index, and the third digit. So eventually coming down to 2 fingers for you to have the pincer that you see on the right. Okay? Zaria, who would you like to call to help you to complete the rest of the fine motor skills?
Melissa.
Melissa, are you there?
Hi, morning, Doc.
Morning. So we've gone to doing our pincer grass. What are we going to do once we've had our pincer grass? Because the pincer grass is thought to be the king of all. Once you learn to do that, everything else should just follow right through.
hmm Okay, so from getting that pincer grasp, they start to mature with that pincer grasp. So you end up having more of a neat pincer grasp with it. From there, we start, as we've mentioned, we've taken things up, but we're going to also be, so if they have a cube, they might take it up and they might start banging it, like
No,
especially
no,
if
we
one.
don't bang at that age. We finished banging a long ago.
Oh, really? When do we finish banging?
We finished banging from about 7 to 8 months. We bang in the midline. We've now
Okay.
picked up with 2 hands. We've reached midline long ago, so we banged, so we passed. After you do that pincer grasp, look at that hand on the right. What do you think of next that comes?
So scribbling, taking things up scribbling.
Scribbling, yes. And how do you start scribbling?
Not sure the question.
You just mark up all over the place. You go in no specific direction. It's just fun to realize that you can have
Make a
marks
mess.
all over. Exactly. And then you start going in verticals, then horizontal lines, but we're not worried about that. You scribble, and after scribbling, the next thing that you should be able to do, you have more control now. Remember, we're talking about the intrinsic muscles of the hand. You have more control. You're holding the paper with the left hand. If you're right-handed, you're holding the marking implement in the right hand, and what do you manage to do? Copy a straight line because you have control, you know exactly how hard to press, you've practiced doing the scribbling before, and you're able to now copy a line. From copy a line, what do you do next? And let's go with Giselle figures because it's easier to do.
Okay, so a circle, maybe? Um, and since we've learned how to do a line, sometimes right away or a little after that, we can start copying across. Since we already know.
So we go from a line, we usually go to circular scribble. And I don't know if you have siblings, if you have siblings or little friends, then you realize that the markings go from being more linear to then circular, where you have like lots of E's,
Mhm.
to then one big E that makes a circle. After the circle, you then make a cross, but the cross must show the right degree angles, right?
Mhm.
It can't be an X, it must be a 90-degree angle. From there, what do you go ahead to do?
You can do a box.
Or
A box.
a
No, we
square
don't
or
call
something.
it a square. Thank
It's just
you.
going out the box.
Okay,
But
I
we don't
understand. 2D versus 3D. Square. You're right.
a square, and after a square comes
Triangle.
Triangle.
a triangle. Okay. Now, the same way how we can put the two fingers together and you start having control of the little fingers, then you start to realize there are some adaptive skills that you will learn to do within here. So you will learn how to zip, unzip, button as well, because you've isolated the little muscles in the hand. Okay?
Mm-hmm.
Mm-hmm.
Thank you very much.
Okay.
So we move on to social skills. Can I have two new volunteers? Any new volunteers?
I'll volunteer.
Who's that?
Listen.
Okay, listen, and Gabrielle Peart.
Hello.
Hi,
Hello, good
Doc. Good
morning.
morning.
I told you not to let me come back to this list. So let's go. Think about social skills. Now, however, remember the context that you're in. You've already developed fine motor skills, you've developed motor skills, and so it makes it easier for you to get through with this part of the social parts of it. So let's go. Let's start with where we begin.
They'll start to smile.
To whom?
And
Anybody? Passing
no,
gas?
no, to familiar faces.
Just familiar faces. I'm not sure if I can
So
accept
like
that.
mommy and
Is
daddy.
it
But
is it
there's
when
a
they
term
smile,
for it.
Doc?
I
Social
think
smile.
recognize. Thank you very much. Yes. So you develop a social smile just about when?
Uh, 2 months.
6. Yeah, 6 to 8 weeks when you can really fix properly. Okay. Continue.
Then they start to distinguish mother from others.
I'd like to let's say familiar from unfamiliar because they do
Okay.
recognize the people around them in their home. They
Mm-hmm.
don't cry for everybody. It's the others that come into the home that they're not accustomed to, and that's referred to as.
Uh, I'm not sure that.
Lanisha Morgan, can you help out?
Stranger anxiety.
Good. Now, Gabrielle, between strange anxiety and social smile, what do babies do?
between? Hmm.
Strange anxiety and a social smile. Remember, gross motor development is very much there. They've learned to hold their head up. They can clear their chest. They
Um.
can fix, they can follow past 180 degrees.
Can they imitate expressions yet, Doc? Like facial
No,
expressions?
no, no,
No.
no, no, no.
Eye
Okay.
movement.
Oopsie doopsie. Can they
Go
look? Oh
again?
yeah. Can they look around?
Eye
Yes! You
movements.
ever notice that a baby will never have their heads down? It's only in that first few weeks of life when they can't control their heads. They have to look in the position that their parents put them in. There's nothing to look at the sheet. If you're up lying on your back, there's only the ceiling to look at. But once you're able to have head control and you're able to rotate your head, the next thing is for you to become interested in your environment and to start looking around, right? You're starting to show interest. And as you show interest, that's how you start to recognize who are those familiar persons from who are those who are not as familiar. Okay, let's move on. What happens once you've gone looking around? Then you start recognizing you don't like when new people come around. That's your strange anxiety. From your strange anxiety, what's the next big step that we tend to see?
Hello.
Is it too soon for peekaboo, Doc?
No, it's just in time for peekaboo.
And
Somebody
peekaboo.
was about to answer me though. So who was going to
Is it
answer me?
is it that they okay, no, I think
What's the
I
basis?
I
What's a big step behind what's it behind peekaboo? What have you learned?
Object permanence.
Object permanence. Peekaboo, I see you. You've gone. I cover my eyes, but you didn't disappear out of the into thin air. You still exist, which means that when you drop an object, what will the babies do? Look for where it is because you're expected to find it. You no longer can hide things simply by putting it behind your back. You must make an attempt to do it without they noticing that it's behind your back. So peekaboo comes into play. After peekaboo, then not Daniel Drakes, Dana Edwards. What happens after peekaboo? Dana Edwards.
Hello, can you hear me now?
Morning. What
Morning.
happens after peekaboo?
After peekaboo,
Yes.
do they imitate actions?
What do you mean by that? Because
Like,
there's imitation in several places,
copy?
so you need to tell me.
Do they copy? Like they copy what you're doing?
Not quite. Let's
Let's
see.
see.
Jabari. What comes after peekaboo or right or wrong with peekaboo? You can tell me either. Right or wrong with peekaboo? You can tell me either. I didn't
Um,
hear you.
is it that they? I think they.
I didn't hear you.
Oh, you hearing me now, Doc? Morning.
Yes, I can hear you now. Yes, I can hear you now.
Wow, it's a delay. All right. So I think they is that they can play by themselves near other adults. So I think they pattern reach for if there are other children in the vicinity.
No, so some parents are lucky. They get to keep their kid at home. I'll send them out very earlier. But despite that, what parents start to say, Doc, when they come for this visit, they say, Doc, every time I drop him off at the nursery, he's crying. He wasn't crying before. Levine, any thoughts?
Hey, Doc, I didn't hear the last thing you said, but is it separation anxiety that they have?
Separation anxiety. Remember, you recognize that if something is not in plain sight, you know it exists. Object permanence, right? And then all of a sudden you realize, where's my parent going every so often? And you kind of want them to still be around. And you're checking and you're seeing what, and they're not there, you cry. But gradually, after, and that's called your separation anxiety that occurs about a year of age. Gradually after that, you start recognizing, uh-oh, they're not around, but guess what? They seem to reappear almost like clockwork. And you know that they're coming back. So it's not that they have to do it on a routine to be back. They recognize that you come back, and then separation anxiety gradually dissipates. So the basis starts off at object permanence, moving on to separation anxiety, where they start behaving, where they start crying again before they go out, once you leave them, sorry. And then from separation anxiety, you start seeing them doing other stuff now. They've gotten over that, they're fine. Where do we go at about 15 months? Where do we go after 12 months? About 15, 18 months. Somebody spoke about imitation. I will jump the cup and the spoon. That takes practice, and that can be under some adaptive skills as well. So I'll jump that and I will head into the 18-month marker. Somebody spoke about imitation. What are they doing?
Are they imitating like mannerisms, Doc?
Like what?
Like
Ashley Lewis, what do children imitate just around this time? Like
I'm
activities
not
that
sure. Is it
this is when children are at their most helpful stage of life. They want to sweep, they want to dust, they want to do everything mommy and daddy doing until they grow up. What are they doing?
helping with housework, Doc?
I
They're helping with the housework.
imitating parental task. We need to learn the words to go with it, okay? If you remember the title of it, you remember what they do. After that, what do they do? So imitation, and after imitation, what happens? They're up and about, they're walking, they're starting to put words together. What happens? They're no longer putting things in their mouth.
Do they do imaginative play?
No, before we do imaginative play. Kevin Frazier and Cabrina Martin, what are kids doing before imaginative play and after imitation of parental task?
Good morning, Doc.
Morning.
Is it at this stage that they might have some tantrums?
Yeah, but we're not going to use that as a developmental milestone. That's just
Okay.
one of the behaviors that occur. So as you mature, you're at home. The circle that you see the most would be family, maybe daycare. You're walking. You're mobilizing yourself. You're seeing other people now. You have your toys. You're not really inclined to share yet, but you are starting to become interested in others outside your immediate circle. And now you start to go over to where other people are. You're not scared that your parent is going to disappear forever. You're not scared of anybody. You walk over and you go and stand beside the other kids with your toy and you play beside those children. What's that called?
Parallel play.
Parallel play. You have enough language, right? So you will play by yourself beside the kid, but social connections are what really puts us together. And what do we do after that? And you're interested in the other people.
I don't know the correct term, but they just play with other kids.
Then play becomes interactive. All of a sudden you stop hearing mine, 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 and you recognize that guess what? If I want to play with the other children, I need to learn to share, and that gradually disappears. You don't see the kids quarreling over toys. They learn to share, they learn to turn take, and play becomes more interactive. As play becomes interactive, there's also imaginary play. After that, there comes a little competitive streak where we start to do competitive games, and then we learn to socialize within a bigger group. That was a painful review of social skills. We need to remember to go back through that, okay? The last but not least, I left for the one that I thought would be the most difficult to do, and that is language skills. So, any takers for language skills? Ryan?
Kind of.
Hi. We're going to describe language in terms of expressive and receptive. Since you're the first one I called, which one would you like to choose?
Receptive. Hello, receptive.
I can't hear you.
Receptive.
Oh, receptive. Right ahead. Tell
So
me first what receptive is, and then we move on from there.
so Doc, I'm not really sure how to differentiate two, but in terms
Of
of
course you can. It's just too early in the morning.
that too.
Anya Chuck, what's receptive language?
So I'm guessing receptive is how they interpret like sounds and so on. So
I'm not sure if you should say interpret songs, because if you tell me how, if I hear a knocking song, I may say it sounds like a tap, or I say it's a hammer, or so. So it's not quite interpreting songs, but the
it's how they
understanding of
respond
what is
to
being
verbal
said.
communication.
It's the understanding of what is being said. And that's
Okay.
using it in a very strict definition, because you also have to understand nonverbal language. So it's really a comprehension of what is being said, or also of nonverbal language. So tell me what you remember as being one of the first things that you remember on that chart.
So like babies, they would be alert to sound, so they'd move their head in the
Yes.
direction of a particular sound.
And remember, in the beginning, they can't localize song very well, nor can they move and track straight across diagonally. So they start off going first across, then up, then eventually they can localize perfectly. Okay, go ahead.
And then I guess like when they respond to particular faces with smiles, I don't know.
We'll put that on the social skills. They alert to sound.
Then they start to like coo or
That's expressive, but cooing and alerting don't comes close to one another. So they coo, they laugh, they blow raspberries, and everybody knows what that is when they look it up in their book, right? From there, what happens? Da, da, da.
so then
What's that
start
referred to?
working their vocabulary. So they call mommy, dad, well, mama,
No,
dada.
no, no. They
They start
start
saying
babbling. They start babbling, usually da da, and you add the other consonants, but the D's are easier to say, so that's where they start off from. And then back to Ryan, what's one of the big things that happens after that babbling starts? Receptively.
After the babbling is orientation to a bell.
That's in a clinical setting, right? You have to
Okay,
find a bell.
so
How many families have a bell?
no.
She's already said oriented to song, localizing songs, but I said after the babbling or just around the time with the it has to be after babbling just starts.
Mm-hmm.
Ryan,
Yes. No.
what did you just do?
Respond to voice.
Respond to your
Yeah.
name,
Yeah.
right? And if I tell you no, you no
Understand.
can understand no.
Understand.
Around
No.
what age are we doing that? Receptively.
9 months.
9 months. Where do you go from there?
After that, you can use about like 2 words. So
When did we start our single words? How did you jump that? I think Anya was giving expressive language. Anya, when are single words?
I think it's around like 9 months, about the same time they start to like walk, I think.
That's about a year.
Okay.
Okay. And do you expect Ryan to speak after you, or do you expect to speak before Ryan, or do you expect to speak around the same time with Ryan? Or Ryan should be speaking around the same time with you?
I think I would expect to speak before Ryan.
No,
Okay.
no. Statistically, you will speak around the same time with Ryan. It doesn't mean that you per se won't speak before Ryan, you know. It's just not significant enough for us to call it that. Okay, let's move on. What after the first word, what do you do receptively?
You can speak a couple of words together. Well,
No. Receptively, Ryan. Remember, you're doing receptive language, you said, right? So
okay.
expressively, you start using your word. You do maybe you have about five words by the time you're one. And what around that age you're doing receptively?
Follow like one command, a simple command
Yes.
with a gesture.
Okay then. Okay, so you can follow a command. You can tell to somebody pick up the book. You show them where the book is, and then they follow through, right? Moving on from there. Expressively, where do you go after one word? Anya?
So I guess after so they would increase their vocabulary. So from one word to two words.
So vocabulary sizes started to pick up, right? You've gone from 5 words to 50 words and gradually 250 words. And if vocabulary size is picking up at that rate, then it can't be that you're still communicating using one word. Otherwise, we'd be worried about you. So you go from 1 word to 2 words. And when do you start to expect the 2-word phrases to come in?
2 words should be about 12 months.
Yeah, coming across early as 18 months, but you definitely put 2 words together. And what's the one thing we usually like to check if you can do by 2 years, or what the sentence looks like at 2 years? What do you expect them to be saying? Ariel,
Morning.
morning. What do you expect them to be saying at about 2 years of age?
Like sentences, making a sentence.
They give me an example, because there's a specific thing I'm looking for in that sentence.
Pronouns.
Pronouns. I want or me want. And it doesn't need to be grammatical, which is why me want works very well. So at 2 years, you're looking at 2-word phrases, definitely use of pronouns. Remember that some kids will tell you want juice from about 18 months. That's fine. But definitely by 2 years, the use of pronouns. By 2 years, you usually say then that your sentence length will be your age plus another word. So by 2 years, you're hearing the 3-word phrases, by 4, the 5-word phrases, etc. as you go up. And your response to language, to commands also increases. 2 years, 2-step commands, 3 years, 3 steps, and then multiple step commands. When do we do colors? Because that's one of your big markers. Ariel, when do we do colors?
Colors would be 4 years.
So I've
4 years
noticed
old.
that some books have 4, but in general, we tend to say colors are by, oops, what did I do? That colors are by 3 years of age, okay? So guys, it was long. It was like pulling teeth to go through milestones. Yet milestones really are the basis of what you will go on to do in terms of your developmental surveillance, in terms of your developmental screening, and what you're expected to be able to do. So it's difficult then to say that if we haven't learned those as yet, or we can't remember them, then you know it will become difficult for you to remember how to do the other aspects of it. So for tonight, you need to review your developmental milestones. You need to go through it. and just get an appreciation for it. You're not in the clinical setting just yet, but you should start by this week, right? And I'm hoping then that as you move to your wards and you see the kids there, that you start to say, okay, look what he's doing. He's doing that skill. That skill puts him at what age? You don't have to go right across the board as you start practicing, but you need to start somewhere to be able to come back to doing your developmental assessments. Even though we have general ages, must remember that there are variation in patterns of development. We have those children who we call bottom shufflers, the commander crawlers, where they don't quite crawl, but they shuffle around, and the shuffling might be on the bottoms or on the chest. They tend to walk late. Some of them might be hypotonic, especially in the lower limbs. There's also variation in acquisition rate of language, other social skills, play, and behavior. There is such a thing such as familial history of speech delay. However, do not assume that is the first. That is a diagnosis of exclusion. And so children with language delay should always be seen and should always be investigated, especially with respect to a hearing assessment. We do know that there's not just the genetic influences that will affect your development, but also environmental influences. And so when we start talking about writing and knowing colors, then it really goes to the amount of exposure you have. And if you're at home and that exposure is not there, then it will be impacted. There is this general belief that boys tend to acquire language later than girls. Please remember that is not true. Yes, they do a little bit, but it's not sufficiently enough for us to say then that boys will be later than girls. There's also concern about children from bilingual families, and before COVID, there was an upsurge of schools who actually had bilingual classes. There's even one that had trilingual classes, and we enjoy these. We appreciate. We tell parents go for it, as long as there is no history of language delay before they start. So children coming from bilingual families may eventually seem to have delayed language acquisition in one language, but they eventually catch up. And the main reason, if you're late already in one, you don't want to start off having 2, 3 languages to go and learn, because then the delays might be noted even more severe when you could have been catching up with just one language. So I think most of you have this developmental assessment station in one page. I've sent it out more than once. So I'm hoping that you have a look at it. Do you recognize it?
Not really.
You've never recognized it? Okay, I can send it to somebody. I think, Ryan, I still have your WhatsApp, so I can send it to you and then you can share it with the group.
Sure.
And it basically looks at developmental assessment, what you would be expected to do if you saw a child. I say, print it off, walk with it. If you see somebody running, assign an age. If you see somebody jumping, assign that age for that child. Just start off somewhere. There are some things you will have to memorize. For example, putting 2 blocks, one on top of each other at 12 months, at 2 years doing 8 blocks. But those are things that you can practice with, and you can then start looking at other skills. Try to find ways in which it becomes easier for you to learn things. So we often think about 3 wheels at 3, 4 wheels at 4, 2 wheels at 6, little things to help. We're not asking for you to remember each and every milestone, but to at least be able to assess a developmental age in each domain as you go along. Remember that in the developmental assessment, as you go back to school, you will have to introduce yourself to the child and mother, the familiar, hi, my name is so-and-so. I don't know if you got any of that practice last year, but remember it does continue to exist. You will have to observe. You did a class on dysmorphisms on Friday, right? All of that comes into play for you, right?
No,
Some doc,
You did your class? You never had your class on Friday?
Doc,
they probably
classes got pushed to this week because of the whole delay sorting out.
Okay, then, so no worries. You will have that class on dysmorphisms, and you will learn just when you start to observe that those are the features you're going to be looking at. Don't forget the basic things, the growth, length, head circumference, that still has to be going. that you still have to go through, and then weight with anthropometry and nutritional assessment of the child. When you see certain things, know that you need to know the association. So you see a big head, remember to check that to see if there's a shunt. Recognize that those are the specific areas you're going towards once you start your observation and go on to your actual palpation. Remember, you need to make the child feel at ease. Come down to eye level. You don't want to be towering over a child because then it becomes scary. Remember to speak in a calm voice, and they're just as scared of you as you are of them. So calmly approach them, come down to eye level, and have a purposeful introduction of a toy. And when we say purposeful introduction, bring something with you that you can use to guesstimate a developmental age. A crayon is a wonderful thing. Don't come with the fire truck first, and then after that you have to take it away, and then the crying starts. Keep your examination area as clear and clutter-free as possible, and always have a plan as to which domains you hope to start with, but be flexible enough that if it doesn't work, you can change and switch over to a new domain. Once that is done and you understand your milestones, you remember or you can recall your milestones, and you need to know the importance of understanding milestones. And I've often fought with whether the slide should go first or come at the end of it. But we need to know that developmental milestones are useful and that we do it in developmental monitoring or surveillance as well as in developmental screening. We know that the main reason that we're using them is we want early identification, because the later we identify children with delay, the poorer their outcomes become. That there's also an increase in costs, and this goes from diagnosis to intervention to education. And then we also have to talk about long-term costs, ability to contribute to society, as well as long-term care. Now, if you're from Jamaica, then you know that it is difficult to get into special ed schools. And when we think about long-term care, I've never seen one for young adults, not out here. Rarely care is dependent on other family members. So, developmental monitoring. CDC says anybody can do this. You, the parents, the grandparents, whatever, and all you're looking for is for developmental milestones. So when your parents come to you for their well visits, you need to teach them and remind them as you do anticipatory guidance as to what they should be expecting next. And we usually do developmental monitoring somewhere between birth to 5 years. And the reason is that you want parents to recognize the growth in their children. Yes, it's nice to track the rate as well, but to celebrate every single development that a child has. The rate becomes then your problem if you have to start talking about delay. You need to be able, parents need to be able to come to you and say, Doc, these are the concerns I have. So you allow them to start off with it. Let them start recognizing what may or may not happen, and the whole exploratory purpose becomes a little bit shorter. So as they learn what to expect, they learn to identify concerns, and basically they will come to you at an earlier age. When we look at it, we recognize, I'll go back, that there are many areas where parents can learn how to do developmental monitoring. This is just one where CDC actually has an app for milestone tracking. You can go on it, you download it for free, and there are other, WHO has, Bright Futures has, and even in parental books, when you read what to expect within the first year of life, there's a general list of things. If you can't download it, there are even maps that you can look on and read, or ladders that follow through to show you where your child should be climbing or what skills they should be attaining over time. Now, it's fine for parents to go through developmental monitoring, but we also need to remember that we as physicians have our own responsibility, and that includes developmental surveillance. So it's a little bit more than what developmental monitoring is. Monitoring is for the parent to see what their child is achieving. For developmental surveillance, you're doing it as a broader process now. You're going to be the physician, the person who's knowledgeable, who will look at that child over time. And yes, we work in clinic settings, and it means then that you may not see the same child always, but the activities done or the surveillance done should be consistent, so that if Ryan sees the child after Anya, Ryan has documented all the domains so that Anya can continue forward with it. Otherwise, we lose perspective, or we may miss an area that is delayed. So in developmental surveillance, we must elicit and attend to parental concerns, no matter what it is. If the parents don't feel as though you're addressing their concerns, there will be difficulties, because then they will say that, I came to doctor and all doctor talked to me about is that the child is not walking, when that was not what I wanted to tell them. I want to tell her that the foot looks like it's turned in. So remember, you must address the parental concerns first. You must be able to document and maintain a developmental history, and you must make an accurate record of it. But you must make it in a way that anybody who comes behind you can follow through, which means you're going through each and every one of your milestones, each and every one of your domains, and having a developmental age for each one at the end of your visit. You must look for risk factors. So you think about a child who might be a low birth weight, premature, who may have had hypoxic event on the nursery, or somebody who had jaundice. You're looking for risk factors. Protective factors would be the ideal situation. You have a full-term baby, good antenatal care, uncomplicated pregnancy, APGAR score is 9 and 9. And despite all of that, it still can't be said that it guarantees that there will be no issues during development. And then at the end of it, you must be able to make accurate observations of the child. And that's where your developmental assessment comes in. That's where you monitor and you give your opinion as to what is happening in the situation. So when you look at it, you have a parent who comes with a story to you. You must address the story. The story can be very beautiful, it can be very distracting, or it can be straightforward and come to the truth. But in the end, you need to be the one that will give an opinion as to what is happening with the child, even as a general practitioner, because you are the knowledgeable person that will make that decision. In terms of developmental screening or there are tools that can be used, and they're rarely used as reminders. So you may not always remember anything, but it's for parents to fill in before you make that developmental observation. So it would be saying, this could be given to a parent. This can be given to a parent before they appear in your office, and parents are asked, can you fill this out for me, just for me to see where your child is. You can download the checklist, it's free, you can use it in just about any office practice, and it is done at all visits, and there's one for every single age that you can think of that you should be seeing a child, and it just forms the platform that you will use to pivot you into your surveillance. So it's a helpful tool. It can be something that parents can do while they sit and wait in the office. Any questions? I will take that as a nay. From developmental surveillance, we need to recognize that's one tier. The next tier really is developmental screening. And screening is where, again, you would help professionals help to identify children who may be at risk. We're not saying that they have a definitive diagnosis, but somewhere along the way, as you're going through your monitoring and surveillance, you start to recognize, this might not be working out as how we expect it to be. And so it's a little bit more in-depth than monitoring. It may identify children with a developmental risk as well that was not identified during developmental monitoring. And this is important because no matter how great your surveillance is, it is still stated that screening is done at specific ages because it helps to counteract what we may miss or overlook. And as such, it uses a validated test for children at the recommended ages, even if there's no concerns. So in terms of the developmental screening schedule, remember that we do screening at 9 months, 18 months, and according to AAP and even the Canadian Pediatric Society guidelines, it's also done at 30 months. But not all countries has that 30-month visit, and as such, it's just a guideline. For us in Jamaica, we have a 24-month visit, so we definitely do at the 24 months. And in other places, they may do at 36 months. The problem is that we must get it done. Remember that children with additional risk factors may need to be screened more often. For example, PREMS, the low birth weight children we spoke about, the HIEs, and that we recognize that if we don't identify them early enough, there will be delays which will interfere with their growth, their learning and development, and as such, we should ensure that they get further consideration for diagnosis. The pediatric patient AAP guidelines, we can go through, we can follow numbers like if we're joining the dots, and we can follow through. It says a patient presents at our child care visit or their preventative care visit. The first thing and always you do is you do your developmental surveillance. You give them their checklists, you go through it, you remember to look for all the information that you need to find, you look for the parental concerns, you look for their past developmental history, you examine the patient, and during that examination, you make your developmental observation. Now, after you've done all of that, is there any risk, anything that is not right during that process? If the answer is no, you next think about it. Is this a 9-month visit, an 18-month visit, or a 24-month visit? If the answer is no, your surveillance, you've passed it, you schedule the next routine visit. So at a 6-month visit, this could easily be done. At a 1-year visit, this is what the path that we would expect. You go 1, 2, 3, 4, visit complete, and all things are done. And that will happen for the majority of the children. I guess that's why sometimes we get lackadaisical in terms of doing it. However, let's say the 6-monther comes in and mom says, Doc, he's not rolling over as yet. So you've already noticed that surveillance is starting to demonstrate risk. You put the baby on the bed, the baby is not rolling over either. Definitely the answer is yes, you need to administer a screening tool. This is where it gets dicey because screening tools aren't available in every location. It really depends on who you're seeing. But there are screening tools in our passports, and we will go through it. After you've done the screening tool, it then says, is it positive or negative? Because remember, you're taking a history, you're seeing a child, one snapshot, just a quick office visit, 20-25 minutes, you're not seeing what you're looking for. You need to administer the screening tool to see whether or not it is concerning. If the answer is no, schedule early return visit, and you have exited the pathway. If the answer is yes, then it says you must make into referrals to the appropriate areas. Let's go back to number 3. Again, does surveillance demonstrate risk? The answer could be no. But if as long as it's 9, 18, or 30-month visit, we go right back in the same line where you must administer a screening tool and decide what the tool says to you, whether or not you need to make further referrals. So it's a guideline. It's not ink in stone or anything like that. It tells you what the typical schedule would be like, and as you move from left to right, yes, it's left to right, you will notice then that it is a child who you have increasing developmental concerns. So screening, CDC puts it right back to you and says, you know, you're the healthcare provider, you're the one who's supposed to be providing screening. However, screening can be done by more than just a doctor. Remember, the classroom provides an area where you're supposed to be seeing typical children. And we always say, if a teacher says to a parent, well, you know, I have concerns, I have 12 children in my classroom and all 12 are doing this, but I noticed that Joshua isn't doing that. It is a real reason to refer, and parents can refer to the child and family clinic or start that process by seeing their pediatrician or attending their nearest health center. And I always say to parents, make sure the explanation that you get is satisfactory to you and not just an explanation that you still feel uncomfortable about. So it says to you again, look for your developmental milestones, ensure that you do screening at the specific time. It even outlines for you what screening should be done at 18 and 24 months. And the reason why is because you're looking for children who are more at risk, for whom you may need to give an early diagnosis. Now I have 2 screening tools on the picture. I have the Ages and Stages questionnaire, which is a common screening tool. So when you read the textbooks, you will find it there. And there's also a portion of the MCHAT revised that is placed there. So remember we said that it helps to identify, screening helps to identify children who are more at risk. But It's not a checklist like the first one where you just tick through whether the child has achieved a skill or not. So a section of the ASQ looks at it at 18 months. Notice it says you can start administering from 17 months to just about close to 19 months. And it gives you questions for you to look at. Some people say that for this tool, you can email this to the parent before their visit so that if they have not exposed the child to the task, they can do so ahead of time. They can observe if they've never seen it before, like pointing when you parent. If you've not seen pointing, my thing is if you take too long to answer me, that means you really have never seen it. But to make sure that you've exposed them to the skill and allow them to be able to answer the question. So they bring it back as a part of the visit for conversation and to look at. But you need to go through the scores at this just as well. So at the 18-month visit, Claire said, does your child say 8 or more words in addition to mama and dada? So a parent who's preparing for that 18-month visit may get out a book and write down the number of words, because I don't know any parent who literally sits there and documents a number of words a child says unless there is language delay. So usually when you see that, there have been some concerns already. It asks, does a child point to correct pictures when you say, show me the kitty? When you go back and look at the developmental station in one page, you'll see it says, understands nouns. So that is one example. The yes usually gets 10 marks, the sometimes gets 5 marks, and the not yet gets 0 marks. Another area, and this is just to show that in some parts of it, it's not just words it gives to the parents. It gives picture examples for you to know what it is that you're supposed to be scoring. Blocks are not always such a big thing out here, but we said, you can replace blocks by spools, and so that you can use. So it's not like we expect parents to go to buy developmental toys or anything like that. Anyhow, there are about 5 areas that you come off to, and these are documented very much the same way how you develop means and standard deviations. Basically, the ASQ gives you 60 for each area, and for each area it is subdivided into whether you should definitely have concern and refer for further assessment, whether you can provide some interventional activities or give parents ideas of activities that they can practice with their child to see if they'll develop their skills. And finally, where's the clear zone is where you have no concerns. So for example, for communication, where it says cut off, it means a cut off here. The black area really goes back to saying that refer for professional assessment. But it doesn't include the gray areas, which says, probably we can just give some intervention activities, and then the clear areas where there's nothing. So there's a cutoff for each area, and depending where a child scores, you can then decide what area you may need to focus on, or if you need to refer directly to for assessments. When it says provide learning activities and monitor, it doesn't mean you're going to leave the child out there for another 6 months or anything like that. You may opt to see the child back in 6 weeks, maybe in 12 weeks, but I tend not to go beyond 3 to 4 months, because then we want to ensure that we're not waiting too long. Usually at that point in time, depending on what it is, we may go on to do the hearing assessment from the very beginning, even if we're just in the gray area. In terms of activities for toddlers, it may not always be culturally appropriate, but we need to find ways in terms of making similar recommendations. So definitely make a picture book by putting common simple pictures cut from a magazine and stuff like that. Nothing is wrong with that. You cut pictures of a cat, a dog, whatever. But you can also buy a book and have it there. The point is, it is not to make it expensive for a parent. Help your toddler sort objects into piles. They talk about the laundry, putting the socks in one pile, the shirts in another pile. Literally could be the plastic cups, plastic forks, spoons, and knives. You're helping them to sort and arrange that they can do it in. You can use clothes pegs, excepting we usually wait for a little older age, but you can use clothes pegs and cups. You can use clothes pegs and something else. Basically, you're sorting by object. In terms of singing songs, you can find appropriate songs. Run Around the Garden can replace Ring Around the Rosie, but we do sing that, as well as Itsy Bitsy Spider. With television, most of these songs are usually known. So you can provide activities for parents, but you must remember also that parents must be motivated, otherwise you're back at square one where you're still going to refer. So to motivate a parent is not to scare the parent, but to tell them the implications of what may happen. And so you want to work with the parent and not for the parent to be fearful of you. General developmental screening principles. If the results are normal, you inform the parents, you talk about what is expected to go on next, you go through all the different areas from development to nutrition to safety. You're going to do your anticipatory guidance. If you administer it due to concerns, even if you have normal results, we say schedule an early return visit for additional surveillance. And then once the results are concerning from a screening process, you must refer. So the ASQ is one example of a screening tool. The modified checklist for autism in toddlers with revised follow-up, which is the newer version, is another tool. And we're going to go through this one a little bit simply because it is free. You're able to download it. Parts of it are in the passport, and so you should be able to use it to some extent. So remember again, it is administered as part of a well child care visit. When is it administered for those who are listening from before? Hello, when are they administered?
That's 9, 9, 18, and 24.
No, that's when screening occurs. But it states exactly when the MCHAT is supposed to be administered. When is that? I'm going to have to remember names from now. Shanair? When is the MCHAT administered? Zaria? When is it sent? When is it administered? I'm not hearing responses. Did you guys disappear?
Hi, Dr. Garbutt. At 18 months?
At 18 months and 24 months, it can be administered, okay? It ends at 30 months. So it is used by GPs, specialists, and other professionals. So you can see that the speech and language therapist may administer it, or the ABA therapist may administer it. And it rarely assesses risk for autism. The sensitivity is greater than 80%, and it will detect as many cases of autism as possible. However, in detecting as many cases, it will also give you high false positive rates. And we know that not all children who score at risk will be diagnosed with ASD. To help to eliminate the false positive, it now has a follow-up section of it where it gives you additional questions and clear examples how to try of what you're trying to elicit to see if you can now decrease the number of the false positives. Despite that, know that you may still screen positive. It doesn't mean you may have autism. It may mean that you're at higher risk for other developmental disorders, and so the child may still require evaluation for any other delays. It has a nice screening stratification. It says you might be low risk if you score between 0 to 2. If you're less than 2, it says repeat after the age of 2 years. No further action is required unless surveillance indicates risk. And it says if you score between 3 to 7, you may be at medium risk. It says definitely no, you need to go back, look through the follow-up questions, find the questions where the response was not as how you would expect it to be, and then go back through those follow-up questions to see if the child could pass. And then finally, high risk would be a total score of between 8 to 20. It tells you bypass the follow-up questions, just refer the child for evaluations. So the MChat has 20 questions, so you can get a maximum score of 20. You want the lowest score, or 0. The lower the score, the less likely you are at risk for ASD. And it reminds you that don't answer questions on what you saw one time or two times, but basically what is the most consistent response you have seen for a child. So keep in mind how your child usually behaves, generally behaves most of the time. And if you have seen it done just 1 or 2 times, then you know the answer is really not yes, but parents will insist, but yes, it was done. But just you remember what the score should be. Please, and you must answer each and every question. I've taken just one question from here. So the first question really is ask if you point at something across a room, does your child look at it? It's asking you if a child responds to a point. These are more autism specific questions. Remember, it says it has a high false positivity rate and will pick up children who are at risk even for other developmental disorders. So it comes with general question now. Have you ever wondered if your child might be deaf? Does your child play pretend play? Drinking from an empty cup? Again, starting to talk about imaginary play and developmental age. Does your child like climbing on things? You don't need to have autism, but you could have a motor delay, and that would be a wrong answer. If you put no, that would be an answer that we would consider wrong. Does your child make unusual finger movements near his or her eyes? Remember, I asked you guys about hand play, and I said to you, hand play can be is considered typical, but it's the age in which it occurs. So if you're doing hand play at 3-4 months, that's one thing. If you're doing hand play at 18 months, that is not typical at all. And then one of the questions says, does your child point with one finger to ask you for something to get help? Let's pretend that the child said no, and he scored between 0 to 7. It then says, you really should go and look up to see whether, use a follow-up questions to help you get rid of the false positives. This is what the follow-up questions look like. It says, let's call him Joshua. Does Joshua point with one finger to ask for something or to get help? So the parent has the form. The parent fills out the MChat themselves first. That's one way of doing it. The other way of doing it is you administering the form. So if the parent says yes, that's a pass when they've re-looked the answer. Maybe they answered incorrectly, they skipped a question or something. That's fine. That's the least of your worries. What becomes interesting now is that they say no. If they say no, you ask the question how it is phrased here similarly. So you ask them, so mom and dad or Mr. and Mrs. so-and-so, if Joshua wants the snack that's on top of the fridge, how does he tell you or indicate to you that he wants to get it? If the parent says he pulled you to the fridge, he cries in front of the fridge, then it says suggest for you to ask specifically no. So remember, you start off with open-ended questions, you end with closed-ended questions. Does he reach for the object with his or her whole hand and say either yes or no? That's not a point. Does he lead you to the object and say either yes or no? Does he try to get the object for himself? And many parents will say, oh, he's very independent. They look at the positive side of it. And then ask for it using words or songs. So yes to any of the above would say, then you would go and say, oh, so show me how he does it. Because you're not trying to infer what you think the patient might be saying. You want them to tell you clearly and to show you so you don't make any errors. If the answer is no to all, it's a fail. If the answer is at least yes to any of the above, you ask them to show. If the point is shown, then you would have passed, but the answer is no, then you would fail. The item score will still remain a fail, and if you have 3 to 7 failures, then we said yes, definitely you would refer for developmental evaluation. Any concerns with the two screening tools and how screening is done?
Question that you just said 2 screening tools.
Yes, I went through the ASU and I went through the MChat.
Oh, okay, okay, okay.
You missed one of them?
I forgot about the first one, to be honest, because I guess because you went so in depth with
Really?
the
And we
M
just
chat M chat.
started.
No, when I say forgot, I mean you went so in depth with the M chat. I was so focused on trying to understand this one.
Okay. I've given you examples of two so that as you read and you see them pop up, you at least are familiar with what they look like, okay? Now, all of you won't practice in Jamaica, and in the different islands, there are different screening tools that are used. And so I started off with generic ones that are used in the US and Canada, but I'll move in a little bit now about what our one looks like. So Jamaica has its own surveillance and screening, and it gives you nicely wrapped up in this passport. It gives you protective factors. It gives you an area for you to document your immunizations, for you to document anthropometry, so that if you really fill it out well, when we're trying to ascertain whether there's been acquired microcephaly, it should be a simple thing to just flip the book, find the area where head circumferences are documented, and be able to look through it. It also gives you suggestions for anticipatory guidance and referrals. When you look through the book, there's enough opportunities for us to look at our children and be able to ascertain whether or not they're progressing as you would expect, or whether we should be worried about any issues. We look at the child health and development passport. This is just an example. I've taken up the 18-month page and I've shown a nice little pencil mark there. That's for your parents to fill out. It's very similar to the checklist that the CDC would give to the parents and ask them to fill out whilst they're waiting. Again, similar principles applicable within our passport. There's also the MChat, which is on the other side. I've highlighted that just as the 18-month screen. It doesn't have it with a title because it's just 5 questions out of the 23 questions the form used to be at that point in time. It's been revised to the 20 questions now, but it's 5 of the heavier weighted questions, and you should be able to, the parent is asked to complete these before. Parents complete these before they come to see you. You have a part where you can screen the moms and the dads as well. Are you feeling well? Is your father feeling well? Is your partner feeling well? And then it gives you ideas that you can speak to in terms of safety within the passport. Very well done. That's for the parents to do. The ones with the stethoscope at the top left, remember, it's for you to go through. You've already have this background information that the parent has filled. You've done your developmental surveillance. That is your screening. You should be able to come to a conclusion at that point in time. When you look at it, health and development checkup summary, are there any concerns since birth? Parent, you should be able to fill that up. And if you have any concerns from the current visit, and it gives you 5 areas that you can put it into and be able to say, what do you want to do? Are you going to observe, give them activities, bring them back, or are you going to refer for evaluation? So notice that you have these visits between 0 to 5. You have individual visits. Remember, we just looked at all the occasions that you can get visits done. And after 2, you start to see visits being done once per year. Those should all be documented. There's space in the passport for all of this. But there's also space for you to do health education visits during the time of the 6 to 11 when you're in primary level school, that you can write down if you have any concerns as you go through. And it may be, when you're doing those visits for those older children, no, you're not asking about developmental milestones. You're asking about academic performance. So we go back to our 0 to 5, and we remember now, this is the last part of it, developmental evaluation. This is the one you want done the least, because you would have done surveillance and screen out all those who are not at risk. And so you should see fewer and fewer children coming up for developmental evaluation. And those are usually done in a tertiary center setting, or where you have either a developmental pediatrician or a child psychologist or some other trained provider who will administer tests that now compares children to others. I don't think we have any time for a break, so even if we did, we weren't going to take one. We'll move on to developmental delays. So you've done your surveillance, you've done your screening, you've done your evaluation. At surveillance and screening, you may say clinically a child has a developmental delay. And that's because you are going to compare, you're going to say that they're not performing as how you would expect within certain domains. So you look at motor delay, and you will look at language, and you will say, you know, of these skills, this is not where they're not functioning where we expect them to be. But we need to remember that we have to compare children to their peers. So we compare your IQ to the IQ of your peers to know where you stand. And we compare developmental scores to developmental scores of peers to see how significant the delays are. And that word significant is what you're going to use to give a true definition and diagnosis of developmental delay. I don't know how many of you would remember there we go, the bell-shaped curve that we look at in terms of IQ and learning. We say that most schools have an average or a mean of 100. On either side of that 100, within the first standard deviation, we've covered 2/3 of our population. After the first standard deviation, we go down up to 70, and we would have covered another 1/7 of the population. And in all, from 70 straight up to 130, 96% of the population would be covered. The last 4% of the population that exists with this nice IQ that all of us would love to have versus this IQ that none of us would like to have would be only in the tail end of the curve. And when we talk about significant delays, we're talking about delays from below 70 in this 2% of the population. That is what we refer to. So what we look at is having a delay. Clinically, you can say that there's a delay in 2 or more developmental domains, and that's your clinical impression. But remember, you're comparing that kid to that kid himself. You're not comparing the kid to their peers. And that's where the objective tool comes in for developmental assessment. And developmental assessments usually end somewhere just around 60 months, thereabout, because the terminology changes after age 5. And that same curve now represents an IQ curve, that what we look at in terms of intellectual disability. Remember, even though we talk quite a bit about the global developmental delay, we do recognize that delays can occur in single domains, but you really need to prove that that is what is happening. You need to go back through your pediatric history to look at common etiologies which are associated with developmental delay, and that's in terms of your antenatal, your perinatal, and postnatal history, and it gives you just an idea of where these delays may occur. When we look, besides typical development and developmental delay, know that there are other patterns of development which occurs when acquisition of skills occur out of the expected age sequence, the expected acquisition sequence. For example, children who are really spastic may learn to roll over very early, or in ASD, where fascinations may be related to learning. There's also developmental disassociation, where we say that the children's profiles are disharmonic, where none of the domains actually fit into one average age, but they're all different levels. And for those children, when you do their developmental assessment, it is fair to state the developmental level of each domain. And then the very fearful developmental regression, which refers to loss of skills which were previously present for at least 3 months and consistently displayed. And that is the most serious of all that we tend to see, and those that would have a worse outcome. So I think we have time that we can only go through maybe one of the scenarios. Mary, this scenario happened on Saturday for me. Mary is 3 years old. Mom is concerned, but teachers seem not to be. She's currently attending kindergarten, sings her nursery rhymes, knows her numbers and alphabets. She doesn't speak to her teacher, but when asked questions in relation to her work, example, her letters and numbers, she does so willingly, and as previously said, will sing her nursery rhymes with the class. The mother is concerned. Should you, the physician, be concerned? Everyone disappeared? Anybody there?
Hi, Doc. Hello. Are we talking about Jason, number one?
No, we said Mary. You guys are not paying attention.
Mary. Would I be concerned about Mary?
I chose 1 because you have another class at 10.
I don't think so.
Any other opinion? As soon as for reasons here.
So earlier in the class, you were saying that if the parents have a concern, we should take it seriously. So I think in this scenario, as a physician, I would at least look into it.
Okay. So the problem really here is that you have a kid who's not speaking. She does not speak to her teacher. So the questions need to come about: who does she speak to? What do you hear her say? How does she ask for her needs? How does she interact with the other children? Because by 3, and if she is doing letters, numbers, and whatever, and she's singing her nursery rhymes, she should be able to at least provide a 2-word phrase. But that's not only what we want. So what you need to ensure is that you don't have developmental deviation, because that's a red flag for abnormal development as well. Remember I said occurs when acquisition of skills occurs out of the expected acquisition sequence. And in autism spectrum disorders, these may be related to fascinations. Very often you get fascinations with letters and numbers and colors, and children can learn these very early from after 1. Yet you ask the parents, so how does he tell you what he wants? What does he call you? And they have no word or no answer for that. And that's why I said the red flag here, she doesn't speak to her teacher. So you can think about other diagnoses. It doesn't have to only be autism. You can talk about elective mutism, but you need to recognize that something is wrong, and this is a kid who most likely will need to be referred. So I will wrap up here because we're at 10 o'clock. We need to go through developmental milestones. We need to get an appreciation and an understanding for it so that we can use it for our surveillance and our screening purposes. It is painful to go through it, yes, but unless you know it, you can't do surveillance, and it's difficult to do screening. It's difficult to give anticipatory guidance. So you must know them. And it's also difficult to answer MCQs. So you must know them. Once you have them in store, then you can use those to do the other tasks that we're asking. Ensure that you are familiar with when surveillance is done versus when screening is done. When surveillance doesn't go right, what to do. When screening doesn't go right, what to do. And the last part, to be able to identify not only typical development, but abnormal development. And the most common one that you will be faced with is global developmental delay. So have fun, and I think I have another class, I think. If not, I look forward to seeing you guys in clinic. Any questions? Let me escape from here.
Hi, Doc. A quick question. So, in preparation for this lecture, some persons had used Essential Pediatrics by Nelson, some persons had used Berkowitz, and we noticed in the presentation there were some discrepancies as it relates to the timelines for various milestones. Other than thank you so much for the chart that you gave us, but going forward for pediatrics, just to be absolutely sure, is there any specific text that you guys overall would prefer us to use, or would you say
So
to mix
I
it?
will tell you that no matter what text you use, the questions that will be asked will make sure that there's nowhere you confuse them. So I will never ask something that with just a 1-month difference, right? Because we do recognize that the texts are different. Essential Pediatrics is not, I think your textbook is actually Nelson's textbook of pediatrics, isn't it? Your Berkowitz is for 3rd year, but it's definitely not a senior clerkship read. It is for revision. You should have reviewed that last week to prepare for this week. Okay? But I tell students not to get caught up with 1 or 2 months differences.
Okay, thank you, Doc.
Okay then. So everybody have a great day.
Thank you,
Thank you,
Dr.
Dr.
Garba. Same
Garbutt.
to you.
You too.
Thank you, Doc. You too.
You're welcome. Bye
Thank you,
bye.
Doc.
Thank you, Doc. Please remember to stop the recording.